As noted previously, initial management of the aneurysmal subarachnoid hemorrhage patient involves assessing and addressing the ABCs: resuscitation, stabilization, rapid assessment, and initiation of imaging. Once subarachnoid hemorrhage has been confirmed, there are several interventions and management schemes that should be initiated. Start by contacting your neurosurgery team and/or your endovascular surgery team. They may want to address the aneurysm itself nearly immediately. Also, don't hesitate to contact your neurosurgery team if the patient's history is strongly suggestive of a subarachnoid hemorrhage, even if the original CT scans of the head show no evidence of hemorrhage. In initial care of the patient, elevate their head to 30 degrees. This will help lower intracranial pressure. Make sure that the patient consumes nothing by mouth until next steps have been determined by your neurosurgical team. Keep the patient well oxygenated. Monitor oxygenation and vital signs closely. Obtain an electrocardiogram. Subarachnoid hemorrhage can be associated with significant cardiac strain. Rehemorrhage from a ruptured aneurysm is very common with devastating consequences. Elevation of blood pressure strongly increases the risk of re-rupture of the aneurysm. Blood pressure control is therefore paramount. Titrate the patient's systolic blood pressure to less than 140 millimeters of mercury. Nicardipine and labetalol are currently popular agents for blood pressure control in aneurysm patients. Run IV fluids generously. They help maintain perfusion. Run them at around 120 to 140 milliliters per hour in a standard-sized patient. Avoid hypotonic fluids as they worsen cerebral edema and can contribute to hyponatremia. It turns out that patients experiencing subarachnoid hemorrhage are prone to profound hyponatremia. Generally use normal saline for maintenance fluids. Start nimodipine, a calcium channel blocker, 60 milligrams by mouth every 4 hours. This is a medication that limits cerebral blood vessel spasm, a potential deadly threat to aneurysmal rupture patients over the ensuing week or two. In vasospasm, cerebral blood vessels spontaneously clamp down. They do so much that they can cause widespread ischemic strokes. Reverse any anticoagulation or antiplatelet medications the patient may be on in accordance with your pharmacist's recommendations. Also, manage coagulopathies as effectively as possible. You are trying to prevent rehemorrhage from the aneurysm. Although not strongly supported by the literature, we tend to use levetiracetam 500 to 1,000 milligrams twice a day as prophylaxis against seizures. Seizures could cloud the all-important neurological exam and could cause aneurysmal rebleeding. Steroids are controversial. We initially give dexamethasone 4 milligrams intravenously every 6 hours to diminish cerebral irritation and headache for the first 2 to 4 days of hospitalization. Although they have not been demonstrated to help with overall outcomes, they certainly seem to help patients feel better. We use it for all patients unless contraindicated. For example, patients with brittle diabetes, ulcers, etc. Severe headaches should be treated with acetaminophen. Narcotics should be avoided unless approved by your neurosurgical team, as they may obscure the neurological exam. They may also result in straining in bowel movements. Such straining may precipitate aneurysmal re-rupture. Keep a close eye on the patient. Watch for declining level of consciousness. This often is due to developing hydrocephalus and/or increased intracranial pressure from brain swelling. Notify the neurosurgical team immediately if the patient deteriorates and prepare for an emergent, repeat, non-contrast CT scan of the head. Now, after the initial evaluation, the patient may be taken directly to the angiography suites. Otherwise, prepare the patient for admission to an intensive care unit for continuous monitoring and frequent neurological assessment. Note: in patients where definitive treatment of the aneurysm, that is, endovascular or surgical obliteration of the aneurysm, is delayed, treatment with an antifibrinolytic may be initiated. Such medications include aminocaproic acid. This therapy is oriented to reducing the risk of aneurysmal rebleeding. As we've noted several times, aneurysms frequently rehemorrhage after rupture, with devastating consequences. 20% will rehemorrhage within the first 2 weeks after the original rupture, 50% within 6 months. Thus, the sooner they can be eliminated, the better. A critical step in the care of ruptured aneurysms is therefore physical obliteration of the aneurysm through endovascular or surgical techniques, taking away its ability to re-rupture. Endovascular methods are less invasive and have less associated morbidity than brain surgery through craniotomy, and thus have become the principal resource for the treatment of cerebral aneurysms. Endovascular treatment of an aneurysm involves passing a catheter from an artery in the groin all the way to the cerebral circulation and into the region of the aneurysm. There, the aneurysm can be packed with tiny platinum coils to help clot off the aneurysm. Alternatively, a stent can be placed in the adjacent artery to divert blood flow away from the aneurysm and encourage the aneurysm to clot off. When aneurysms cannot be successfully treated via endovascular methods, patients will undergo surgical clipping of their aneurysms via craniotomy. During a surgical clipping, the surgeon will place a spring-loaded titanium clip around the opening of the aneurysm to stop blood flow into the aneurysm. If blood cannot flow into it, it cannot rupture and bleed. Now, please understand, obliteration of an aneurysm by surgery or endovascular techniques removes the risk of rehemorrhage, but unfortunately, the patient is far from being out of the woods. A whole series of complications are still very possible.
So I hope you liked this video. Absolutely make sure to check out the course this video was taken from and to register for a free trial account which will give you access to selected chapters of the course. If you want to learn how MedMastery can help you become a great clinician, make sure to watch the About MedMastery video. So thanks for watching, and I hope to see you again soon.